Sridhar Kalyanasundaram. What is the current practice in the Middle Eastern countries? And do you think this data from Helix will change your practice in any way?
Good evening, everyone. Thank you, Kiran and Dr. Suman and the team for this opportunity to be with this August panel. I'd like to congratulate Sudhin and Professor Bhatt for the excellent talks and interesting perspectives, we may say. And of course, there is always different perceptions when it comes to differing views and perspectives. So we have to understand both the arguments for and against and have an unbiased approach. That's my view. In terms of the Middle East, I mean, very interesting scene that we have tertiary centers and we have the level 2 centers. Not everyone will have the cooling facilities, and rightly, as explained earlier, that level 3 centers will be the ones who cool the babies, and geographically, it's not very big. So we have in United Arab Emirates, for example, we have 7 Emirates, which you have the option to heli transfer or road transfer, and within 1 to 2 hours, traffic is usually not a major issue. And the issue we have is that the yardstick medico-legally that is applied here is similar to Western criteria. So they're not going to go by population statistics, and it's a huge variation, multi-ethnic expat population here. So if you say genetic variations are going to impact, will we be cooling the patients who come from US or UK, but not the ones from India or Sri Lanka? It's very unlikely that would be acceptable in a scenario like this. And we know from all over the place, I mean, the perspectives on the genetic part is very interesting. And both Dr. Bhatt and Professor Sudhin had these views. But the key thing is, we know that population does play a role in diabetes, for example, in hypertension, for example. And there are multiple studies, long-term studies, which have been done in a Chinese population moving to US, or in the Framingham study, and even Barker's hypothesis, they say that the people from a certain background have a higher risk, but that doesn't mean that you would not use a certain measure totally in them. And one point I would like to make regarding the population number or the Apex Institute numbers, I mean, if you look at the population of India of 1.2 billion, even 15 to 20% caters to medium to high risk groups. We have good facilities. It's going to be almost equal to the population of US and 4 or 5 times the population of UK. So if you're talking of huge numbers when you talk of a big country like India, and as you said, we have come fairly advanced. As far as the Middle Eastern experience is concerned, there are a few publications, and especially from Saudi Arabia, where they have applied in Saudi Arabia as well. The government setups are comparable to the Western setups, and so the studies have come from them. They do have a similar transfer policy for the sicker babies who are delivered in centers who don't have cooling. They will be transferred, and the expectation is there from the authorities here that we should go by the Western standards. So if you don't cool babies, you may be in trouble if they fulfill the criteria. So medico-legally, we have an obligation. I was looking at the MacCool study where Qatar was involved as well, and Egypt and Saudi Arabia were among the other centers in addition to Canada, similar to Professor Bhatt's talk on, the brief mention on the magnesium sulfate in cooling, and they also showed comparable results, but it was a pilot study, and I have to follow up whether they're doing a long-term study. So this is the published evidence, but as I'm working in a tertiary center, and many of my colleagues are working in the government institutes, which are tertiary centers, the outcome we have that we have observed, we don't have very solid papers on this, but the outcomes we are observing is comparable to any of the Western data. And population background, the obstetric care, these are going to make a very big impact. So I'll be discussing it in the next point that we will discuss as well about patient selection. So with this, I'll close this part of the talk.
Thank you, Dr. Sridhar. Thank you so much for highlighting that, just like in front of law and justice, all are equal. Similarly, you can't really make a difference and say, you're from US, you're from India, I'm going to cool you, I'm not going to cool you, your genes may be different. So for highlighting that, and also you're going to elaborate on the population. So you also highlighted about the medico-legal aspects, which are so strong in the Middle Eastern countries. I do see that some of the participants are raising their hand. Ask Dr. Sridhar, what are your thoughts on this NNF statement?
Thank you, Dr. Suman, and thank you, Kiran, for summarizing it so nicely. Obviously, the focus here should be on the points that we have learned from the Helix study as well, that outbound babies are not a homogeneous group. And before I address the point on the statement, I would like Sudhin to consider the question of, there was a study published by Vanya Olivera, on the pilot project for the Helix trial. And even there, it was clear that 70% of the babies were outbound, and you had a clear differentiation in the outcome between outbound and inbound. So could we not have gone back and changed it? And the other point is awareness of what exactly happens in the Indian scene. When we talk of a center like Institute of Child Health in Chennai, for example, everyone works hard, no doubt about it, every decade, but there are so many constraints. And when we talk of outbound babies coming to a center like Institute of Child Health, is mostly hospitals who have burned their hands and they want to push away a dying baby. So essentially, we are talking of a situation where we are having a very sick baby who has not received the optimal care, and that optimal care is going to damage the brain even more. The absence of a good Apgar score, the absence of documentation of the Apgar score, the absence of the COD pH, and the early seizures, the subacute changes on the brain MRI, it doesn't mean there is suboptimal antenatal care alone. It may also mean the postnatal care has been suboptimal. We all know that cooling is going to prevent further brain damage from the secondary brain injury. It's not going to reverse the brain injury that has happened. And we are talking of a situation where the brain injury is poor in this case, mainly because outbound babies are a totally different category. So it's not to criticize the study. You have done a great job. It's obviously a very difficult position to organize, as Dr. Sita said, the biggest number of babies who may have the power. But did we choose the right babies? Professor Bhatt and Dinesh also asked the same point. Did we choose the right patient load to come to a conclusion which we aim to extrapolate to an entire population in all the low and middle income countries? My point is, it's not. You have not chosen the right population. So we should go back to the drawing board and think about why we didn't change based on the pilot project. You have spent a lot of money. The funding is there. The training has been there. The data collection has been meticulous. I accept everything. But if your soil is not the right one, are we going to get the right results? And we cannot compare a baby who is outborn, who has received very poor care, to a baby who is inborn, who is going to get the optimum care from the beginning. We may show genetic differences, but it's not going to be easily understood by many of the people. And what is clear is that they are cooling babies, they are seeing a benefit. And so unless we have comparable populations, we cannot. And the NNF statement, my main comment is going to be what Kiran said in the end. The registry is going to be critical. People should really have a clear documentation of what kind of babies. It was very interesting when Dr. Dinesh presented his data that close to 60% are still outborn. And so if you say don't cool outborn babies, it's not going to be the answer, because outborn babies also do not need to be discriminated. But we should be very careful especially the referring center should be very careful in documenting from the start, trying their best to optimize the care, documenting from the start what exactly is being done, be very transparent. I know it's a very litigious subject. It's a high risk of medico-legal problems. So people may hide information. They may try to push the baby away. That happens in any setup, but in India, it happens even more. They just want to wash their hands off the patient. Please go to the next center. It's their headache after that. But we should come to an open system where we address the problem. We give them the clear information, try to optimize the care and documentation, and the registry is going to be critical. So I was thinking of saying the outborn babies should not be cooled, but if you don't have enough information on the outborn babies, do not cool them. Or if you don't know or you don't trust the center where the baby is coming from, it's safer not to cool. So you may damage such babies in cooling. So my comment is to be, the NNF has to take the lead along with the IAP in creating a registry with utmost urgency. Having the statement is important, but more important is to monitor what happens subsequent to that. After the ACT study, the WHO came out with very clear criteria, and it's very nice to know Dr. Suman was part of the team. So such criteria have to be applied, by our bodies first and maybe the WHO later, partly because this will protect our team medico-legally. Most of the questions on the chat about the medico-legal implications, I don't think people would be blamed for not cooling in the Indian scene now. And at the same time, you won't be blamed just on the basis of the HELIX study for cooling a baby as well. That is not enough evidence, especially when the scientific community sees that the patient chosen for the study is not appropriate. So both sides won't work. You don't need to be worried if you don't have the facilities to cool or transfer, and you won't be blamed for cooling after the HELIX study as well. So this is my humble viewpoint, that the registry should be applied immediately, and there is a huge responsibility on the referring team in entering the appropriate data. So the referred team, the team to whom the baby is referred to, can make the appropriate decision. Thank you.
Thank you, Dr. Sridhar, for saying it so very clearly that now it's a total no blame game in India. You can cool, you will not get blamed. You don't cool, it's still not a standard of therapy. But I totally take your point that we need a registry, and that's what we had actually started when we started doing with the Mira Cradle.